So good afternoon. Welcome, everybody. My name is Dr. Clifford Mitchell, and I am the director of the Environmental Health Bureau at the Maryland Department of Health and Mental Hygiene here in Baltimore. I'd like to welcome everybody to this Public Health Grand Rounds, which is co-sponsored by the Department of Health and Mental Hygiene and the Johns Hopkins Mid-Atlantic Public Health Training Center. On behalf of both of us, I'd like to welcome you to this Grand Rounds. And the topic for today is lead poisoning, CDC's new target for prevention. Before we start, I'd like to give a couple of upcoming trainings for everyone to be aware of. I'd also like to mention to everybody that if you are online or want to be online, you can visit our website, and the website has all of the upcoming trainings. It also has a way for you to contact us during today's Grand Rounds so that you can ask questions online. We will moderate those, and after the formal presentations, we'll take your questions from the online audience as well as the audience here in Summer Hall here at the Johns Hopkins Bloomberg School of Public Health. Please also, if you are watching online, please sign in. This allows us to know both how many people we have and it gives us an idea of how to plan future events. So please sign in if you are watching online. We are very pleased today to have with us two experts in the field of lead poisoning prevention. And this is a topic that, as you know, has gained singular resonance over the last year or so because of changes at the federal level in terms of recommendations on the recognition and management of lead poisoning and lead exposure. Our first speaker today will be Dr. Anna Navasasian, who's an associate professor here at the Johns Hopkins Bloomberg School of Public Health. Dr. Navasasian got her PhD here in epidemiology in 2005. She is a physician and epidemiologist with a special interest in the health consequences of widespread environmental exposures. And she has done considerable work in the areas of chronic health effects of heavy metals, including arsenic, selenium, lead, cadmium, and other trace metals. Dr. Navasasian works closely with collaborators here at the Department of Environmental Health Sciences, and her research has helped clarify some of the issues in low-level exposures to populations, which is particularly relevant for today's discussion. Our other speaker today is Dr. Pat McLean. Dr. McLean, who is at the University of Maryland in the School of Nursing, has more than 30 years of experience in public health programming as a nurse and public health professional. She's worked at the local, state, and national level on numerous advisory boards and with departments of public health. And she works very closely as chair of the state's Lead Poisoning Prevention Commission with the Maryland Department of Environment and the Maryland Department of Health and Mental Hygiene on issues related to lead poisoning prevention. Her background is in nursing, as I said, from the Francis Payne Bolton School of Nursing at Case Western Reserve University. She also has an MPH from Johns Hopkins from the School of Hygiene and Public Health, and her doctorate in public health is from the Johns Hopkins Bloomberg School of Public Health. It's a pleasure for me to introduce both of these distinguished guests and to have them come up and address this issue of CDC's new target for prevention for lead poisoning prevention.
So thank you, Dr. Mitchell, for your introduction. And hello, everybody, and welcome, and thank you for being here, all of you who are on site and also all of you who are online. So today's, our goal was to talk about lead poisoning and how the new CDC target is going to change the way we do public health practice, and also how this might really impact lead exposure for children especially, but also for adults and for the population in general. So both Dr. McLean and myself will be presenting this topic and will be discussing this topic. And so we wanted to frame the question first talking about exposure, what has happened in the US. This is very well known, and which are the current sources that we are concerned about. Also, kind of do a small overview about the health effects, especially at the low, moderate levels of exposure that we are currently exposed to, and include, as I said, both children and adults. And then also talk about the prevention strategies. So I'll be covering mostly those topics, but then Pat, Dr. McLean, will also be covering some of these issues, like to complement some of the things that I will be not talking so much in detail. And then the second piece of the talk, Dr. McLean will focus on talking about the new target and which are the implications and which are kind of the challenges and also the next steps. But first of all, as Dr. Mitchell mentioned, I've been working on this topic with a number of collaborators here at Hopkins and also from outside Hopkins. So I wanted to acknowledge them, and because most of the research that I have been presenting and discussing, many of the ideas, we have this very active group on the impact of heavy metals at low, moderate levels of exposure, including lead, on chronic health effects. And so I wanted to acknowledge Dr. Wayar, Silvergold, Virginia Weaver, and also some of my students and postdocs, Esther Garcia, Andrea Apostolou, some of this research that they've done, I'll be showing it, and also Dr. Fadrowski, Schwartz, and Rothenberg. So we all know that lead, it's a very toxic metal. It's been used since very ancient times because of its physical and chemical properties that make it very useful for humans in many different ways. It was so that use by humans made it very ubiquitous in the environment, especially in the last century. And through mining, smelting, the production still used today in batteries, ammunition, metal products, medical research equipment. We still have lead in many of those products today, resulting in issues with recycling of these equipments and what happens with recycling and additional pollution of the environment. Also in ceramic glazes, still used today, and in paint, where it was banned several decades ago. In gasoline was the big issue with spreading really lead into the environment, and it was phased out in the 70s. And as a result, lead is in air, food, drinking water, rivers, lakes, and oceans, dust, and soil. Something that is interesting to know is that this change in lead in the environment, and many of you probably know this, we know it's been very dramatic historically. And if we look at the ice, snow strata, we can see that the levels dramatically change, especially in the 20th century. But actually starting with the Industrial Revolution, that resulted in this change in environmental exposures that spread all around the globe, including the Arctic ice. And in the 20th century, the main two sources of exposure were lead paint, so the white lead curve here in the figure, and you can see how in terms of tons of lead consumed, it was really dramatic, very high consumption during the beginning of the 20th century, and then dropping down as it was banned and phased out. And for tetraethyl lead used in gasoline, it peaked during the 70s, and then it was kind of also phased out and finally banned, and so it went down. So very, very different patterns of exposure. With respect to lead in gasoline, that resulted in really very high concentrations in the air. And here we only see the drop in air concentrations after the banning of lead in the use of lead in gasoline. And you can see how that really parallels the lead consumption in gasoline. And those big changes, and we can imagine that those also went up. We don't have the up in the curve because we didn't have such a good monitoring of lead in the air before. So monitoring lead in the air was a consequence of the awareness of what was happening. So we have a very good data to track it down, but not so well to track it up. But also we have good data from the biomonitoring perspective to track it down in the human populations. And we can see how in using the enhanced data, bloodlet levels went dramatically down from the late 70s to the early 2000s. And this dramatic change resulted in changing completely the distribution of bloodlet levels in the population. We went from a normal distribution, when lead was very common in the air, in the environment, to a very skewed distribution. So we were able to push completely the distribution to low levels with this very important public health intervention of banning lead in gasoline, mostly, and then banning the lead paint and the other initiatives. But the banning lead on gasoline is really the critical issue that changed the distribution. And I would say this is a beautiful example of a population-level intervention, prevention intervention, as compared to a high-risk prevention intervention. So in a high-risk prevention intervention, you would just focus on the kind of high-risk groups and try to protect those people. In a population-level type of intervention, you try to protect everybody and change that hazard among everybody. And that really makes the distribution to push towards the left. No? And so this was very successful, but now this result, and this is the second histogram is from NHANES 3, but it's very similar today, forward to the left, but still similar, no, and very skewed. So that result, in lots of groups in the population that remain at high risk. So when we think about the big public health success of banning lead in gasoline, we need to remember two things. First, that lead remains in the environment at very high concentrations compared to what humans were exposed before the Industrial Revolution. So even if the levels have decreased dramatically, doesn't mean that the problem is not there, because there might be health effects at these very low levels still. And second, that we still have a group of people with this very, very long tail that remains that are at very high risk. And those people are not homogeneously distributed in the population, but they are in certain groups, certain areas. So among those groups, those areas, we can also think about additional measures, even if it could be a high risk, but it would be like population-level interventions that could also help those populations that are in certain groups. So children are definitively one of those groups at high risk, and both because of heavier exposures, because of their behavior, and because of they drink and eat and breathe more per weight compared to adults. And also thinking not just in terms of exposure, but in terms of susceptibility, they might have special metabolic conditions that might make them, put them at higher risk. Such as, for instance, in terms of lead, because of the neurocognitive effects of lead, the fact that the blood-brain barrier is not yet fully developed early in life. So those are important aspects that make children be in a special group. The other one, if we think about the relative bioavailability of ingested lead from soil, certain types of lead, depending on the source of lead, the type of soil, for instance, lead paint has a relatively high bioavailability, so that's going to also contribute to these children being at increased risk of exposure. So in this figure, even if it's a little bit outdated, but it's a good representation to give us an idea that it's really when children move from their first year of age to their second year of age where there is a big change in the risk of lead exposure, resulting in some cases in very elevated lead levels, here using the cutoff of 10 and higher. No? It's categorized as 10, between 15 and 19, etc. in the figure. But you can see how there is a big change. And why is that? It's because the big change in behavior between a baby that doesn't move and a toddler that is immediately moving everywhere, no? And being exposed to lots of different risks. And there might be other reasons, but that's one of things that we can think very plausible. And this risk remains really high during the second, third year of life. Then it goes a little bit down, but it still remains quite high in subsequent years. And in this figure, again, this kind of just documents the change in average lead levels, these are medians, in recent enhanced data, so recent years in the US, but just comparing 99, 2000 to 2001, 2002, we can see there was already a big drop. So each year we are doing better. So that's good. We still have a lot of things to do, but that's kind of good. This is population-wide, and we need, and Pat is going to really show us how what happens at the average level, in the average population overall in the US, doesn't necessarily translate to all the high-risk groups that I was mentioning earlier that we need to be paying attention to. And so when we talk about also lead and lead exposure, lead biomonitoring, we are always using, or we generally use, blood lead. And blood lead is the biomarker that has been used to for monitoring and surveillance of lead exposure. Why is this? First, it's a good, we can measure it relatively easy. Second, it's a good, the half-life of blood lead is quite adequate to monitor ongoing exposures. We can then see if interventions work or not. So it's because if it eliminates the exposure, then you would expect that in a month or so, this child or this person should have lower blood lead levels. But lead, it's not easily eliminated from the body. And that's also to always remember, no? Is that lead exposure is going to be stored generally in the bones that accumulate most of the body burden of lead. And in bones, the lead, its half-life is decades. However, it's not used for biomonitoring because it will be first of all, it's expensive. There are hazards from doing the X-ray fluorescence and other issues. But so generally, this bone lead is mostly used for research and not for biomonitoring. So which are the health effects that we are worried? So many, because lead is a pluritoxicant, so it affects many organs and systems in the human body. The best known health effects are the neurocognitive effects, and those have been shown both in children and adults. In adults, I am not going to be talking much about the neurocognitive effects. I'll just mention it briefly now. For instance, we know that there is effect on cognition as people age. However, there are not good studies actually done looking at the impact of lead in Alzheimer's or the epidemic of Alzheimer's nowadays, things like that. So that research would be really important to really understand what is the impact on not just cognitive losses in cognition, but really actual disease. And so that kind of areas of research that maybe are challenging to do, or it's hard to get money funding to do those type of studies, but I think would be really important. In addition to the neurocognitive, the nephrotoxic effects of lead have been known for a long time at high levels. But in recent years, we've known more and more about the effects at low levels, including very low levels as less than 5 microgram per deciliter. We can see very clear dose-response relationships with worsening of kidney function. So this is actually quite compelling, and we've seen this both in adults and children. The immunotoxic effects of lead have been also described. It induces anemia. Those are generally at higher levels, but also it's less well studied or known at the lower levels. It can affect bone and teeth metabolism because it replaces calcium. It's classified as a probable carcinogen, although the carcinogenesis of lead is not as clear as for other metals, such as cadmium or arsenic. Actually, that fact made it possible for lead to be added to gasoline. When people said at the beginning in the early 20th century, got this idea of using lead, some people raised concern about adding a heavy metal to gasoline. And people are starting to look at cancer, and they actually saw that it was not easily carcinogenic compared to cadmium or compared to arsenic. And then they thought, okay, it's good, it's not toxic. And so that's an interesting thing kind of to know. But nowadays, it's classified as a probable carcinogen, but not as a definitive carcinogen. That is what these other metals are classified as. And then finally, the cardiovascular outcomes of lead are a group of outcomes that are very important because of the high burden of cardiovascular disease in the population and the potential of lead to really be contributing a portion of that cardiovascular disease risk. So I am going to be talking a little bit more about this in a few slides because that's the research that I am myself being involved, so I would like to describe it a little bit in more detail. So with respect to the neurocognitive effects, since these are so important for children, I wanted to bring kind of the study that summarized most of the evidence that was available at the time. This was published in 2005, and it pooled studies conducted in the US, in Europe, in Mexico, and in those studies kind of consistently they could see that there was a decrease in IQ with increase in blood lead levels. But what was interesting is that they tried to assess the shape of the dose response. And what they saw, so in this model you can see, if you use the straight line, you look at the straight line, it's a 5-knot spline model. That's a very flexible type of modeling. So it's trying to just look, what does the data say? What is the shape of the dose response? And if you then compare with a log linear model, where you are trying to force in the data the relationship to follow this log linear fit, you can see they look both very similar. So what does that type of model tell us? What this is telling us is that the impact in IQ is actually stronger at low levels of lead than at higher levels. So that means that a change in 1 unit of lead exposure, like for instance, from going from 1 to 2, is much worse in effect than from going from 20 to 21. So like if once you have 20, one change in 1 more unit is not as bad as from when you start at very low levels. So that's what this model shows. And you can see here the impact from going from 2.4 to 10 micrograms per deciliter, sorry, there is an error here, has an impact of 3.9 IQ decrements, versus going from 20 to 30 only has a 1.1. So that's what the model says. And actually, this model works very well for IQ and also for blood pressure levels. So that's telling us that both for blood pressure and for IQ, this could be true, that the impact of lead at these low levels is even worse than at high levels. Doesn't mean that at high levels is not bad. At high levels is bad because you accumulate all the effect, no? It's just that it doesn't go much, much worse. So then what happens with adults, no? So in adults, we are very worried about the health effects of lead. Adults have generally always been not considered so important as compared to children in the lead world, I would say so, no? As a researcher that have done research in adults, I think that would be a fair thing to say. And it's important because their exposure accumulates, as we say, and because of many of these health outcomes that we are talking about, such as nephrotoxicity, cardiovascular toxicity, is really important for adult populations. So cardiovascular outcomes could be very important, and I wanted to talk a little bit more about this. And the first thing I wanted to kind of to show, just as a maybe anecdotal a little bit, is that if we look at the epidemic of cardiovascular disease, especially coronary heart disease in the United States, it really tracks very well the changes in blood lead levels in the US population due to the gasoline, with a very high increase in coronary heart disease from the early 20th century. We don't have the line going on, but coronary heart disease that is mostly due to atherosclerosis, was mostly inexistent at the beginning of the 20th century, very low rates. It went up dramatically until the late 60s, early 70s, exactly when gasoline was, and then it was ban went down dramatically too. And actually, in the cardiovascular disease world, there are always like the traditional control of risk factor, traditional medical interventions do not really fully explain this big drop. So there is room for environmental exposures to really play a big role. But we don't have all the evidence to make that argument. We really need those strong studies. So let's see what we have, no? There is some suggestive evidence. Actually, the first evidence that we have available is really old. There is even a study that is much earlier than this one, but it was in French, so I thought that I will bring this English paper published in the British Medical Journal in 1886, where they describe arterial effects in autopsies of people who had died of lead gout. And so Saturnine gout, it's called, because Saturn was the god in Rome for the metals. No? And so it says that the reasons for this effect could be due to atherosclerosis, to hypertension, and to some of renal effects of lead. I thought this is amazing that already so early on, they really could have a hint of what was happening. So we did a systematic review a few years ago, and we tried to compile the evidence on lead and cardiovascular disease. And the conclusions of that review were that for blood pressure levels, for hypertension, we had good evidence of a causal association, based both on the epidemiological evidence and the experimental evidence. 2 minutes. Sorry, I am sorry that it's because I didn't know that I only had 2 more minutes, and because I thought it was until 1:30 and that we could have like 30 minutes each to present. But that's okay. I am going to kind of go a little bit faster. Sorry for this interruption. So in conclusion, we have good evidence for blood pressure levels, but some very suggestive evidence for coronary heart disease and for some other cardiac function abnormalities. So I am going to skip the cardiovascular evidence, but in general, as a conclusion, as I mentioned, it was very good for blood pressure and suggestive for the other outcomes. And this has important implications for prevention in adults that have so far not been generally considered in lead prevention programs. And one of the first implications is what's happening with the safety standard for workers. We are still at 40 micrograms per deciliter with absolutely no change since for many, many decades. So if we compare what has happened for lead safety standard for children versus adults, there is a big, doesn't make any sense. For children, we've been dropping it. For adults, it has remained very high. So in terms of lead poisoning prevention programs that mostly focus on children and also somewhat in pregnant women, so those are based on surveillance, secondary prevention measures, and Pat is also going to cover a little bit more about this, but basically doing case management of children with elevated blood lead levels at different cutoffs over time, and also trying to identify which are the most important sources of lead exposure for those children. And then in terms of primary prevention, that is going to be really important to really prevent exposure in the population at large, but also in those high risk groups of the population that I was mentioning. There is a need of identifying the most common sources and to do some types of activities so that we can make sure that children are not exposed. Something that I noticed myself, because I do a lot of tobacco smoke research, is that secondhand smoke was generally not included in lead prevention programs. And so that's something that I was myself interested because preventing secondhand smoke is feasible. It's relatively easy to do, actually, as compared to preventing lead exposure from lead paint or other things that are so complicated. So that's something I wanted to really look into. So we did a project a few years ago with actually one MPH student and then also with some of my postdocs. She finished the work, and Pat was also involved. And so what we found is that both using cotinine as a marker of secondhand smoke exposure or counting the numbers of smokers who lived at home, children with increasing secondhand smoke exposure had higher blood lead levels. So you can see 48.7% higher blood lead levels with increasing no matter after adjustment for sociodemographic and even the year the home was built, supporting really secondhand smoke being an important source of exposure for lead. And this was consistent for most subgroups. The other thing that we did is to try to see if this could be related to inhalation or to exposure through dust, and maybe intake through dust. And so when we accounted for dust, there was no change in the association, suggesting that direct inhalation could be very important. This is not a surprise because lead is actually in the gas phase in secondhand smoke. And we can imagine that exposure to lead through inhalation can be important for children who live with smokers. And I took this picture from one of the major Spanish newspapers. It was published on the front page with an article related to something else. It was some parents protesting for something. And I couldn't just believe the picture, no? Because not only we have the mother here, but also there is somebody else behind who is also smoking. So this child is exposed to secondhand smoke, but also very possibly to lead. And this is kind of a source of exposure that we are not accounting, and that could also contribute to lower blood lead levels. So what I thought in terms of implication from public health from this research is that really there is more need sometimes for talking between programs and public health programs and prevention programs, because we can learn a lot from each other. And even sometimes maybe people cannot quit smoking, but maybe people can learn not to smoke within their houses, just to smoke outside, to smoke far away from their children. And that's going to benefit and reduce lead exposure. What could also help families to think about secondhand smoke, because sometimes people in certain groups of the population might not even be so aware of the health effects of secondhand tobacco smoke, or it might be hard for them to quit. And the fact, if they know that this could prevent lead, could be an additional motivation for them to not smoke in front of their children. So this was kind of all what I wanted to cover, and now I'm going to give the stage to Pat McLean, Dr. McLean, and she's going to be focusing on this new target and what the implications and what should we do.
Great, thank you. Okay, great. So it's great to be here, and I wanted to follow up with a little bit more information on one of the outcomes that I think is really important along the lines of the neurocognitive effects, and that's educational attainment. And lead has been associated, besides the neurocognitive measures, has been associated with poor school performance as measured by end-of-year grade exams in reading and math, particularly at third grade, failure to graduate from high school. There's real concern with regards to this because kids who don't graduate from high school then are not going to go on to get jobs and to have productive lives. So it has a much bigger effect than a health effect alone. So what do we know about reading readiness? Again, another marker that we measure usually at kindergarten. About 25% of American children enter kindergarten not ready to learn to read. If children can't read by second grade, then they typically will have really severe problems and failure in school. So there are many, many programs geared to reading readiness at the kindergarten level for kids who still don't achieve benchmarks in kindergarten, first grade, and certainly in second grade for those that are still having difficulties. So the lack of readiness is very costly. It's much cheaper to intervene earlier rather than later. Just for example, the cost of preschool or kindergarten, $5,400, repeating of one grade in Virginia, $8,100, and if we go to special education, $16,400. So big costs, big differences. Some of the studies that have been done, and you may know of these, this is also Bruce Lanfear's, this is using NHANES data, 1988 to 1994. You can see here the clear dose response from the lower blood lead levels, where you have the higher test scores, to the higher, which is over 3 micrograms per deciliter, relatively low, where you see the difference in the outcomes and very statistically significant. Mary Lynn Miranda and her colleagues at Duke studied Black and white English-speaking children in North Carolina with one blood lead level, and they looked at third grade reading outcomes. And as you can see at the lower blood lead levels, and these are two models, one using average and a linear blood lead model, and the other using blood leads grouped around 2, 3, 4, 5, etc., micrograms per deciliter, and then 10 and above. And you can see this very sharp decline for the blood leads that are below 10. My own research looked in Providence, Rhode Island, looked at kindergarten reading readiness and lead, and found a very similar trend with blood leads of, with increasing blood leads, the decrease in readiness. And these are very statistically significant changes as well. So I want to talk a little bit in this section about who's affected, what the recommendations are when they're effective, how we can improve primary prevention, barriers and opportunities, and a little bit about next steps. So I want to thank a number of people. I've more in touch with the public health community, from Patrick Parsons, who chairs CDC's laboratory group that's been looking at the laboratory issues associated with these new recommendations, to the staff at MDE, who run all levels of the program, Peter Simon from the Rhode Island Department of Health, Kate Scott from Baltimore City Health Department, Jane Malone from the National Center for Healthy Housing, members of the Maryland Lead Commission, in particular Barbara Moore from Mount Washington Pediatrics, who's made me very well aware of some of the issues for providers and families, and Mary Jean Brown from CDC. So just another look at this amazing decline in blood leads over time. And I want you to think about this group of children here, 1995, 1996. You can see from this table that we have 15% of children tested in those years who had blood leads over 10, 15%. Now, these children are now 17 years old. They're should be graduating from high school. Many have started or will start having children, and they've had significant lead exposure. So even though we're tracking down here and we're really interested in what's going on here, these kids are with us. They're part of our population. They're in our schools. They're having children, and we're going to be bearing the burden of this exposure for a long time. So I want you just to think about that as we think about these new recommendations. So I think there are many groups affected, certainly public health, environmental health, housing, education agencies at all levels, primary care providers who will be in positions to see children and their parents when they come for health care, families who are impacted who have children with higher lead levels, and advocacy organizations that work on their behalf. So what is recommended? There are 13 points, basic points in the recommendations. The first is it eliminates a level of concern. Based on the research that Anna reviewed, you know now there's no safe level of lead, and this certainly is acknowledging that. The recommendation set up a reference value based on the 97.5 percentile of the population blood lead in the United States of children ages 1 through 5. Right now, that is 5 micrograms per deciliter. It could change. It could go up. It could go down. It's going to be reassessed every 4 years. And the reason for this is twofold: to identify children and to identify environments with lead hazards. So we're thinking here primary prevention. The third point is to develop and implement a national primary prevention strategy to ensure that no children live in or spend significant time in homes, buildings, or other environments exposed to lead hazards. Now, we're not going to get there tomorrow. We have lots of older housing in our stock, especially in cities like Baltimore. But we have a lot of progress to make. And I will point out that the push for primary prevention did not start with these recommendations. 2004, we had additional recommendations put out for primary prevention housing-based approach. And so the CDC, the state and local lead programs all over the country have been focused on primary prevention for many years. This is not a new idea, And there are many elements already in place across the country in most states and local jurisdictions, although they vary across the country. So on the clinician side, the recommendations talk about clinicians serving as a reliable source of information on lead hazards and taking a primary role in educating families. They talk about environmental assessments prior to blood lead screening. Why should we wait for a child to have a higher blood lead level? We should be finding out, are they at risk in their environment? And this can be done before the child even starts to walk. We have clinicians notifying families and monitoring health status of children with confirmed blood lead levels. The schedules for retesting, confirmation follow-up are all in the guidance. So it's pretty clearly laid out. I'm sure there'll be questions, and it'd be important to talk through how that's actually done, but there's a pretty good set of guidelines there in the new guidance. Now, for states that don't have mandatory reporting, we do in Maryland, and many, many states do. Clinicians are basically called to ensure reporting of blood leads at or above the reference value to local and state health and housing agencies, and then to collaborate to provide appropriate services. I think for many of the areas across the country, we have required reporting, so this will not change the role of clinicians. Our reporting here and across most of the country is based on laboratory reporting. Other recommendations are education on primary prevention in homes, in child-occupied facilities to eliminate hazards. And again, we're targeting families, providers, advocates, public officials. Further developing the primary prevention infrastructure. And this includes data sharing between health and housing, development and enforcement of preventive standards for housing, for rental and owner-occupied properties. I would add that in Maryland, about half of our new cases of children with blood leads of 10 and over are in owner-occupied properties. So this clearly is no longer a problem of rental housing alone. Identifying funding for lead hazard remediation, always an issue, and providing families with information so they can protect their children from home environmental hazards. And families are a very important part of this picture, and they will do what they can to protect their children within the homes that they live. Recommendations continue to work with elected officials, health, housing, code enforcement agencies to adopt policies that protect children from lead exposure, and adopting primary prevention strategies to reduce exposure in soil, dust, paint, and water before children are exposed. So we're emphasizing environmental assessment, and we're emphasizing remediation of hazards and protection of children. Action, not just measurement. With regards to the final recommendations, targeting of multifamily housing. If there are lead hazards found in any unit in a multifamily property, like an apartment or a duplex or a home with 3 or 4 units, then lead hazards found in one unit will trigger actions in the rest of the units unless those units have been tested and found to be free of hazards. This is very important in terms of trying to continue the prevention and not let go opportunities where other children are at risk and could be poisoned next year, the year after. We want to really take what we can and take action as quickly as we can. The guidelines encourage health outcomes research based on interventions that can maintain blood leads below the reference value. We don't have that kind of research done now. So we can't say, well, if I do X, then I'll have the effect of reducing the blood lead. We don't know that. So there will be the need for outcomes research. And then with regards to priorities of research, the CDC has established improving the use of screening data, developing the point-of-care analyzers, the handheld analyzers that I'll talk about in a little bit that could be used to promote further screening, and improving knowledge of epigenetic mechanisms of lead action. Now, overall, this is a major shift to primary prevention at all levels. Again, as Anna had talked to you earlier, no level can be thought to be safe, and these guidelines are clearly calling for action that's unacceptable to wait until children reach a specific blood lead to qualify for lead-safe housing, that is not where we see this going. We're also not going to further secondary prevention. We will be doing follow-up with individual children, but we want to focus on primary prevention and looking at population. So I'll try to explain that a little bit better. Now, when are they effective? The guidance was issued on January 4th of this year. In May, the CDC reviewed and issued a response that they concur in principle on all points, but had concerns about the ability to carry out some of these guidelines based on funding. I will point out that the CDC budget cuts eliminated funding for state and local CLIPs beginning in fiscal year 2013. We went from $29 million in fiscal year 2011, which then funded local programs in fiscal year 2012, which is what we're in right now. And in 2012, we dropped to $2 million, and that's the budget amount. It may change when the House finishes its markup, but the budget amount has been this year $2 million, which does not include money for state and local childhood lead poison prevention programs, or CLIPs. So despite many national efforts to restore funding and working with congressional delegations, senators, many of the state and local CLIPs are facing layoffs as of September 30th of this year, the end of the fiscal year. Nobody knows at this point if money will be found to keep people on board, to keep programs in place. And I believe CDC is intending to do a survey of that, but it's still unclear what will be done. And states will implement based on their data and their resources. And so I think we don't have a clear idea of all what will go on across the country. Now, just as we think about prevention, want to just step back and think about where children are exposed to lead, how they get exposed to lead from all these sources that Anna talked about. There are many, many sources that children are exposed to in their home. At levels of 5 to 9 micrograms per deciliter, the lead in housing and soil are important contributions, but many more factors can actually impact blood lead at this lower level. Housing is really important, has long been identified as the major culprit. Rental and owner-occupied, and houses built before 1950 are at highest risk, but homes in poor repair and homes undergoing repair, renovation, repainting with high exposures to dust are at very high risk. So there are new sources of lead exposure identified regularly. It seems like every time you turn around, there's a new source that's been found of some imported product. And here are some of the more recent sources of lead exposure that were identified, I believe, here in Maryland. So you can see the wide variety of toys and products that children might actually be exposed to in their play. Other sources of lead that we've seen here include coal and surma, cosmetics applied to the eye in certain cultures, medicinals, metal charms and jewelry, toys, candy from Mexico, lead in cigarettes we've spoken about already, and of course occupational exposures of parents, those doing construction, and environmental exposures in the do-it-yourself home repairs. Many young families buy older homes and then try to renovate them while they're pregnant with children, increasing the exposure of the pregnant woman and potentially children to lead dust and lead dust hazards. So how can we improve primary prevention? My thoughts, my recommendations on this, not described in the guidelines completely. But I think one thing we can do is we can use environmental assessment opportunities in the office to identify children at risk. We can use photos, drawings, to try to find out if children are exposed to known hazards. This cannot be really gathered by just an oral interview. So I think pictures are going to be really important in identifying, what kind of house do I live in? Do you live in a house that looks like this? Or you do live in a garden apartment that looks like this? Or do you live in a row house? Do you have peeling, chipping paint that looks something like this? So these kinds of things to really, because we're not in the home when child is in the office, how we can actually try to identify risky situations. It would also be possible here in Maryland to directly access age of housing data through the online tax registries or housing registries. And then, most important, assessment alone isn't going to do it. Connecting environmental office assessment findings with solutions. So the key here is the solution, and states and jurisdictions have different approaches. In Maryland, providers could assist a parent to prepare a notice of defect in cases where they learned in their assessment that the child was exposed to peeling, chipping, flaking paint, and they found out the house was built in, say, 1924. So this triggers action by the property owner based on their responsibility as established by Maryland law. And then it triggers, may trigger enforcement actions at the local or state level, and should trigger action to take care of the hazard in rental housing. Now, providers are going to need to know if the child lives in rental housing or owner-occupied housing here in Maryland, because our laws vary in terms of what our requirements are. So in privately owned housing, there are many risks as well, particularly the renovation, remodeling, and painting, and poor maintenance for owners that are very low income and do not have the money to regularly maintain their homes. So clinicians are going to need to know who can follow through on these identified problems and how to contact them, just like we would any other referral. It's not a mystery, it's not rocket science. I think, again, connecting the office assessment with solution, there are potentially risky consumer products used particularly in key ethnic groups. This is a little girl has surma or coal applied around her eyes. This is a Reebok charm that actually fatally poisoned a child several years ago, and lead in jewelry is a real problem, and the city of Baltimore has been very proactive in testing jewelry and getting stuff removed from the market, but something we have to be continually observant about. And having laws in place and enforcing the laws are really important strategies that states are pursuing. I think we can also encourage parents to address smoking. And I would say that we've been very successful in convincing many at-risk pregnant mothers their unborn child would be at risk if they smoked during pregnancy. And I see evidence that many mothers, high-risk mothers, have stopped smoking 3 or 4 times during the 3 or 4 pregnancies they had. But our message is not that they should keep smoking cessation in place because smoking is harmful to their young child. That message has not been told, and we need to do some work in that area. And I think it's certainly an area that can be addressed by clinicians. Blood lead tests. Now, I would say that blood lead testing is only a small part of the recommendations. It's something providers do. They've done it for a year. It's part of established healthcare protocols, but it doesn't change exposures. And on its own, it's unlikely to result in changes in population health. Unfortunately, we're not really doing a great job of blood lead testing. Nationally, based on the NHANES data from 1999 to 2004, only 41.9% of Medicaid-enrolled children aged 1 to 5 had ever received any blood lead tests prior to their NHANES exam. This is during a period when it was required that all Medicaid children be screened with a blood lead test. Now in Maryland, between 2005 and 2010, we have screened 55% of Medicaid children, and in Baltimore City, 62%. So better than some of the national average, but I would say that's not good enough, and DHMH's target for screening is 80%. So we really need to beef up our approach to screening and not feel that we can make exceptions for certain parents or certain children based on what we think we know about their status and their exposures. In addition, there are laboratory implications, which I'll discuss shortly. Selection of the proper tubes are going to be very critical. in terms of getting accurate measurements of lead. The follow-up testing guidelines are in the guidance: confirmation of a blood lead 5 to 9 within 1 to 3 months, and follow-up testing every 3 months until blood leads start to decline, and then every 6 to 9 months. So you can read those suggestions in the guidance. I'm not going to go into them right now. On the blood lead laboratory situation, I don't know how many states are in the same situation we're in Maryland, where our capacity, really in terms of state laboratory capacity, is restricted to oversight. We used to have a CDC reference lab. We do not have a lab doing blood leads here in this, at the state anymore. So we are restricted to being able to oversee the laboratories that are doing analysis on children in Maryland. So our surveillance requires reporting laws, an active program to ensure quality and follow-up. The accuracy is really affected by the equipment used in the analysis, the type of machines, and the supplies used in the blood draw. And there may be need to consider different methods of quality control, like submitting spike samples into the blood lead sampling stream, as we do now with environmental sampling. So as the blood leads have dropped over time, the analytic methods for blood lead testing have changed. And you see we've gone from flame AA, ASV, to Delft's cup, to graphite furnace, to ICP mass spec. And these are the little handheld machines, the lead care machines that are currently in use. Now, there are issues related to these methods. And I've highlighted the ASV method with using the large laboratory equipment and the 2 handheld pieces of equipment, because the limit of detection for these methods is higher than the limit of detection for both either graphite furnace or ICP mass spec. The costs are much lower, and they are also not automated. So we have some issues in blood lead measurement. If we're really interested in getting below 5, we are not going to be able to use some of these ASV methods. Now, in Maryland, MDE has looked at where we are with the laboratory reporting for 2011. And as you can see, 80% of the reports to MDE came from labs that used graphite furnace, 12.7 ICP mass spec, and only 7% or so in the ASV. So most of the blood leads coming in to Maryland, to our lead registry, were done on instruments that can detect these lower levels, which is really great. Sorry, there we go. So there's also a problem of contamination and error that's related to the sampling collection, the storage and transport, and the analysis. And at the higher blood lead levels, and this is a blood lead of 26.5 micrograms per deciliter, this average kind of error of this magnitude represents a 6% error in the blood lead. But when we go to a blood lead of 4.5 micrograms per deciliter, the same degree, the same magnitude of error is, in fact, 33% of the magnitude of the sample concentration. So that's a concern in terms of, if we get to lower and lower levels, how accurate are the findings? So we also have some problems with specimen collection, and it has to do with what's called for. Often in pediatrics, we do a variety of tests together. And then these are the tubes recommended for these tests. However, the requirements for blood lead require the royal blue top EDTA or tan top lead-free tubes. So we're going to really need to look at the equipment being used for these multiple test situations to make sure that the tubes in which we have blood for blood lead analysis are in fact going to yield accurate results. In terms of healthcare reform, I think there's some opportunities here to use existing programs to assess for lead safety. We have really highly increased funding for evidence-based home visiting programs to parents and young children. Outcomes of interest include the outcomes impacted by lead. Where children live in older housing, somebody is going to have to address lead. The advantage is we already have people in the home. They could identify at-risk conditions, and they could connect families with solutions, as they do with other problems that they identify. So I think this is an opportunity that could be looked at the state level in terms of making this a requirement, especially in areas where there are a lot of children living in older houses. The medical homes and federally qualified health centers in high-risk areas could also use home visitors to assess for lead safety in the home environment. There has been much discussion and quite a bit of evidence to show that it makes sense to send home visitors into the home for children with asthma. This could be, and it's being evaluated for other issues as well with regards to young children. This could certainly be done for children with either at-risk home environments based on the environmental assessment or with a higher blood lead level. We can also use care managers in the clinic setting to coordinate the assessment and follow-up. And that's certainly a role for nurses that I think is very feasible. So state and local health departments have been facing a number of challenges, particularly lack of resources. And I think there's really a need to identify resources for public health. There have been state and local budget cuts in the past in Maryland where we had somebody who was at least half-time available for lead follow-up. Now we have no one available. So it's really important that we consider how we're funding our state and local infrastructure if we expect people at the state and local level to do follow-up of any kind or coordinate care. Again, I mentioned already the drop in funding, which is very significant. I think there will also be the need to monitor individual and population lead levels. And we should be thinking about population. Prevalence of blood leads of 5 and above are not equally distributed in the US population. The NHANES data, that's the result of NHANES population survey. But in Maryland, for example, based on 2010 data, we have 0.5% of children greater than or equal to 10 and 3.6% greater than or equal to 5. So we're already higher than the NHANES would suggest. However, there are places that even have a bigger problem. And in my study in Providence of kindergarten students, and these were kindergartners between 2004 and 2006, we had access to all their blood lead levels. 20% of the children in kindergarten during those years had at least one blood lead level greater than or equal to 10. 67% had at least one blood level greater than or equal to 5. That's the majority of children. I would suggest that since we don't really look at populations this way, like who's in our public schools and what was their history of lead, we really don't have as good an idea or an understanding of the kind of exposures that are facing public schools and children in public schools. The history of exposure is really quite extraordinary. Another way of thinking about this is that only 31% of Providence kindergarten children had all blood leads under 5 microgram per deciliter, compared to, I think, the expectation of 93% for the NHANES population of 1999 to 2004. So really considerably different problems in urban areas with older housing and other areas with older housing as well. So focusing on using the tools we have to identify hazards in housing before children are poisoned. I think this could involve visual assessment and dust testing in neighborhoods that are identified at risk, followed by targeted efforts to enforce housing code and to provide assistance where needed. The real idea, I think, here is to look at populations, not secondary follow-up of individual children identified in a doctor's office. So really to change our focus and our direction. So there are many different ways, different things that can be done. I think where the majority of children are exposed, for instance, like in the Providence example, it would be wise to consider something like universal access to preschool education. We know there are effects of lead on school outcomes. We know preschool education makes a huge difference in terms of children being ready to learn and then succeed in school. We need to do many things at many levels to try to ensure that our kids have a healthier future and a brighter future. At state and local health departments, definitely lots of opportunities to expand data linkages, linking blood lead with educational data, using electronic medical records to track screenings and health outcomes, having databases that are where the registry data is accessible to private providers so they can look up to see children's blood leads, and this is part of the infrastructure in Rhode Island. And then certainly assessing the analytic capacity for blood lead laboratories, as we discussed. There are other issues that will be taken up by other federal partners. The dust and soil standards currently in place are not health-based standards, and those are being looked at, I understand. And certainly to focus more on prevention, we're going to need to address those. There's going to be a continued need to emphasize prevention in the activities that generate lead dust. Renovation, repair, and painting. Funding for lead hazard control in many different ways is going to be important, and I think early education is a part of the solution, and we certainly need the Department of Education involved in the discussion. What I see as barriers, I think the funding is one of the biggest barriers. If there were program layoffs in some of these programs, it would severely impact capacity. We have long-standing programs with long histories. It's a complex subject, takes about a year for someone to really get their arms around this issue. And if we have layoffs of key people, it would be very difficult to put the infrastructure back into place. Then I think the current capacity of public health system really needs to be addressed in a holistic way to make sure we have the capacity going forward to address the public health needs of our populations. On the opportunity side, I think we have evidence and policy that supports primary prevention as a priority. We have studies that show that addressing lead in the environment is cost effective. We have a national program with state and local affiliates of more than 20 years of experience and more than 22 years, I believe, of funding at the categorical funding of these state and local programs, including Maryland. That's a huge, huge asset. And healthcare reform includes some new approaches and may increase assessment options that we have in the home going forward. So that's it for me. Oh, I'm sorry, next steps, I think, funding. Definitely, I think people need to be involved and ensure that we get additional funding for these programs, that people care about it. People need to hear from you on the Hill. Additional guidance may be needed from CDC. No size is going to fit all, but I think the state and local health departments have sufficient information to begin to develop plans. They won't be here overnight, but they're working on them now, and it's something that you can expect from them in the future. In terms of population health, the focus will be on housing and other known exposure sources, and I expect we'll see a lot more collaboration with the provider community as we figure out ways to focus on primary prevention, provide information to families, empower families to take action, and increase coordination in ways that really are meaningful in this area. So with that, I'm done, and I think we're open to questions and comments.
So I want to thank both Dr. Navas-Acien and Dr. McLean and invite them both up to the podium. Thank you very much, both of you. Come on up. And we'll take questions both online and here in the hall. And so let me just ask, first of all, are there any questions in the hall? And if I can just ask you to go over to the microphone so that the audience at home and online can hear you.
Thank you for your excellent presentation. I was wondering if there's in the light of the funding cuts, if there's been any move in some areas to coordinate with parish nursing programs to provide personnel for testing.
I don't know that. I mean, I think we need to look at all kinds of options that can be used to continue the work. So that's an idea that could be taken up at local level. Thank you.
And I might add that in my own capacity at the Department of Health and Mental Hygiene, one of the things that Dr. McLean touched on was the issue of the state and local health department planning, and the state health department here, working with the Department of the Environment, is in fact planning to ask for public comments regarding some of the issues that Dr. McLean and Dr. Navasasian have mentioned, particularly in regard to how we manage, from a health department point of view, these low levels moving forward, and what to do about the issue of looking backwards at children who have been tested previously with low levels. Yes, madam.
So looking at the funding cuts and having experienced the frustration from a clinic perspective in identifying a child with a, only a 14 blood lead level and not being able to get any response anywhere for anything, what are the options for parents to be able to be proactive, know about how to test their environment and get access to materials to be able to test their environment, because they're not going to be able to find somebody else from the health department or somewhere else to come in and do testing, so that they can be proactive about their care and know whether or not their remediation efforts have been effective?
I think that's a great question, and I think health departments are going to have to find ways to make that information available, widely available, probably online through websites, and again, information that will enable parents to take action, not just general information about how children are exposed to lead, but specific things that they can do. And many health departments have that kind of information and have developed it. I think having a good package and making it available is probably one of the key steps that health departments, you'll see them taking.
Yeah, and I think one opportunity also to deliver that information, that package, would be through the contact with the primary care physicians, the pediatricians. No, I think it's sometimes a little bit frustrating to see that the test is administered sometimes as if it was a vaccine or something. Even vaccines, you need to provide information. No? There is not much information provided to the parent when you get those tests, either when you get the test or even when you get the result. They just tell you, oh, you are fine, great, no? You can go home. And sometimes you don't get even that quantitative value of what your result was. There is just this, you are above or below the cutoff. And I think providing the quantitative values to know how far or close you are to the cutoff is very important for the parent, especially knowing that there is no safe level. And second, to know what can you do, even if there are risks in your house. So delivering that package at that care point of contact, I think, will be useful.
Sir.
So I have a very specific question. So how the early education may help the children already having higher levels of lead?
Actually, early education has been shown to be extremely effective in having children be successful in school, and it's very good. It's been seen as one of the ways we can invest in our society going forward, is to invest in early education for all children, especially at-risk children, but really all children. And my study, my dissertation study, also shows that children exposed to reading readiness education in school did well regardless of their lead level. And so I think that we have not done the studies to determine to what degree education can begin to turn around some of these effects, if it can. We don't know the answer to that, but we know that some children that had very high levels of lead have gone to college. Some of them are teachers. Some of them have, some of them are probably in this room. So those aren't just great individuals, but the families and the kinds of education probably that those children got, in addition to what they got at school, probably made it possible for them to be successful. Can we replicate that? That would be our aim. Our goal is to not just have low levels on screening tests, but all those kids that have been exposed to lead, we'd like them to be productive, we'd like them to be employed, we'd like them to have successful lives. And we have to really think about the big picture here.
I believe we also have some online questions from our folks online.
We do. The first one I'd like to ask is kind of a technical question about blood sampling. The recommendation seems to eliminate an initial venous blood lead result as confirmatory. The recommendations state that you need to confirm a BLL above 5, even if initially a venous, due to the possible contamination. In practice, this means the child has to be tested twice with a venous. Can you confirm or comment this information?
That is what I understand from reading the guidelines too, and I think certainly I think we're talking about confirmation in 1 to 3 months is what the guidelines recommend for that too. Again, because there could be error in the result, and just want to see, is this a sort of a stable blood lead level? Was it elevated up to a 6, and then when you test in 3 months, is it down to a 2? I mean, I think really trying to figure out where the child is. And we know that testing at any one time, because the blood lead turns over, but if you have a lot stored in bone, you could continue to have a higher level or as high a level over time, but depending on the exposures. So I think that's the reason. I think it's a good question. I don't have a better answer.
Okay.
And I should just add that for capillary testing, which is more prone to contamination, the advice would not be to wait for 3 months, but to confirm it with a venous blood right away, because there is at least the possibility that that's an artificially increased test. So that applies to the first venous sample as opposed to a first capillary sample.
But I would say that even while you wait to have those results from the second test is to check if there are any obvious sources, meanwhile, just in case, not to also help.
And to this microphone, I believe.
Yes, obviously in some communities the housing stock's a big issue. And so what success, do you have any examples of some successful approaches to dealing with the old housing stock and being able to handle that exposure from that perspective?
Well, I think Maryland is a good example, and we are, and our law addresses rental housing, and doesn't require what we call full abatement, but now requires that rental housing has to be pre-50 housing has to be registered. It has to meet standard of care, which is free of peeling, chipping, flaking paint, and meet the dust standard. And we have another level in Maryland, which is that the properties will also meet, I believe, there 7 or 8 kind of standards for work to be done in the interior, particularly around the window and having cleanable, washable floors. I believe that our standard, while it hasn't prevented all elevations in blood lead, has helped populations, and we have seen many fewer cases in rental housing. I think another approach is the approach that's taken in Massachusetts, which requires full lead abatement in all houses, rental, owner-occupied, often very expensive, but they have an extremely effective program there where if you call and say, I have a child and we're living in a house with peeling, chipping paint, someone will come out and test that area with sodium sulfide, and if it's positive, they will take enforcement actions to get the property into compliance. So they have a mechanism in place there. I think it's very positive. So as we develop, as more houses kind of are torn down, older houses, and we get more new houses, we'll see probably less of this problem, although there's still often a problem of lead in soil where, we have new houses built in older urban areas where there had been older housing. So I think, I don't think there's a magic answer. I think states and mostly this is done at the state level, and state laws are really trying to look at, how can we protect children and make sure that properties are safe, and what can we do? And there are probably as many answers to that as there are programs.
And I should mention also that the at the federal level, the new renovation, repair, and painting rule, the RRP rule that was promulgated by the Environmental Protection Agency, which is now going to be run in Maryland by the Maryland Department of the Environment, is one way to focus not so much just on the rental housing, but anyone who is going to be doing any kind of work where you're going to be doing major renovations. You are going to find that your contractor should be and will be trained specifically, and will in fact do those things that need to be done in order to prevent lead exposure and to reduce the possibility that your home in the future will have any problems with lead. So that's one area where you're seeing that we're again focusing on housing stock regardless of whether it's rental housing or owner-occupied housing. Another online question?
We do. This one is in regard to community gardens and lead in the soil in the community gardens. With the rapid growth of community gardens, what's being done to educate the public about the potential for lead in garden soil, especially in vacant urban lots? It seems there is no current standardization. Information on websites are either conflicting or out of date.
Good question, and I think it's a great opportunity for people to get involved in activity and also to grow food. I think many of the states that I have worked with in the past have there have been researchers and program people actively involved in the gardening movement to actually test the soil and make sure that soil is low lead level, often bringing in replacement soil. It is an issue, and certainly if we're redeveloping urban areas where housing has been torn down, we need to pay close attention to that. There are a number of options that have been evaluated in terms of having safe urban gardens, safe places to grow things in your yard, even if you have a heavily contaminated yard, as they do in Boston. But I think it's something we need to pay attention to.
From the research perspective, there are a few studies that have actually evaluated which plants absorb more lead from the soil versus which ones do not. So that could be quite useful in terms of what do you decide to grow. No, do you decide to have tomatoes versus carrots? Carrots are going to uptake much more than tomatoes. And then the other thing is also the research has also shown that if you eliminate the soil and put new soil, that helps. But that helps like momentarily, 1-2 years, and then it seems to kind of come back the old level. So this should require like that you do permanent surveillance and check and change the soil also over time.
So we'll take our final question, Madam.
Thank you very much. A very interesting presentation. As we talk about these very low blood lead levels to keep this surveillance, and I think primary prevention is a very important aspect. And I also trust that engagement of people in order to change behaviors, to take actions for something, it has a lot to do with the risk perception. People need to realize, to perceive, to give a value to their actions. So I wonder if you have, how are you dealing at this area of risk perception and the message? Because informing the public is one, but do they get it? Do they act based on this information? So if you can comment or, whatever, just one
Sure.
point that caught my attention. Thank you.
You probably want to comment too. I mean, I think when you look at the number of children impacted, when we look at going from blood lead of 10 to a blood lead of 5, we're we're looking at basically an 8-fold increase in the numbers, and it's still being unclear to healthcare providers and parents. My child has a 6. What does that mean? should I be worried? I think a lot of people right now are very worried, are very scared. I think the providers that I've talked to, public health and medical providers who are getting lots of calls in, people, you know, I have a 6, what should I do? I'm worried. And so I think as we get clearer about follow-up and making sure that we're reducing exposures, I think it'll become clear. I think actually the current situation, people are more concerned because more people are in fact impacted, and it's clear now that this is something that affects a large percentage of children in our population, not just a small group that we could say, well, they're over there, they're not us. They are us, they're our children. And so I think this might have a good effect, but I think it's important that people know that 5 is not protective. No level is protective. And that's something that I think is hard to kind of get your arms around.
Dr. Navasasian, anything else to add?
I think it's just important to disseminate the information adequately, you know, and I think in that sense the research studies are important because they are the ones that sometimes can tell people what's happening and which are the health effects that we are more worried or not, at which levels, and the dissemination of those findings. And so how do we do that, in which venues?
So I want to thank everybody for attending this Grand Rounds. Next month we'll be talking about influenza at the Public Health Practice Grand Rounds. And if I may take a personal note here, for the past 5 years I've had the pleasure of working with the staff at the Mid-Atlantic Public Health Training Center to put together the Grand Rounds. There's one person who really more than anybody else has been responsible for these monthly Grand Rounds and the success of this series. Molly Mitchell, and parenthetically, we are not related. Molly Mitchell at the Mid-Atlantic Public Health Training Center has really been the force behind this Public Health Grand Rounds series, and this is the last time we'll have the pleasure of working together as she's moving to a new position. So I just want to thank Molly for really being the person who, more than anybody else, has been responsible for a really astounding success of this collaboration between the Department of Health and Mental Hygiene and the Johns Hopkins Bloomberg School of Public Health. And for all of you online, I just want to say thank you very much for attending. We will be back next month, and thank you for attending.